I now invite Dr. Leila Mohan ma'am for the keynote address about tackling myopia progression, choosing the right tools for the right patient. Ma'am needs no introduction as she is a senior pediatric ophthalmologist from Comtrust Eye Hospital, Calicut. She is a well-known national and international faculty in pediatric ophthalmology. Thank you, ma'am. Over to you.
Thank you, Dr. Anila, for that introduction, and thank you for this opportunity. Actually, Dr. Ishmi has given a very comprehensive note of how to go about myopia. So I'm just touching upon choosing the right tools for the right patient. Often we have some universal policies like environment management, and low dose atropine is not specific to some patient, but there are some conditions where we would prefer one to the other. So from passive optical correction to the active preventive measures to prevent the onset and the progression of axial elongation and myopia. So other than just a refraction, genetics, ethnicity, time spent outdoors, near work activities, accommodation and binocular status, all these have to be taken into consideration. And we know that Indians have less progression compared to the East Asian ethnicity. And NIM study has shown that we don't have so much of a progression as in the East Asian and Asian countries. So parental myopia is a risk factor, single parent having twofold and both parents having a threefold risk. So they have to be, that has to be kept in mind when we are managing these patients. Younger age of onset, they also have a greater progression. So some common environmental factors like time spent outdoors, we already know from all these studies, Singapore myopia study, CLEAR, the collaborative longitudinal ethnicity study, all these have shown that luminescence of more than 1000 lux is protective for protection, which is given only in outdoors. Outdoor luminance is about 10,000 lux compared to indoor, which is 150 to 200 maybe. So reduced time on near tasks, early exposure to high near tasks, especially within 25 centimeters, is a factor for progression. And it is all the more risky in myopic conditions when they do their work in the night, in low light. So meta-analysis have shown that there is 80% more chance of progression in continuous near work. So taking a break every 30 minutes is good for these children. And COVID pandemic also has shown us that digital gadgets have they have increased the progression. So contrast management is another field now. High retinal contrast overstimulates retina to overgrowth and myopia. And so there are some lenses which show some contrast management strategy also. So there are some guidelines. The impact guideline, myopia management guideline, put forth by the Indian Myopia Awareness and Research Group in 2022, and it was published in 2023. We know that no one size fits all, and there are no universal consensus, especially for ethnicity. We have to consider Indian context as well. So these are some of the 6-step guideline validated in 2022. Identify true axial myopia, whether it is axial or not. Mapping the risk factors which she has already pointed out. Pick progressive myopia. Who are the progressive myopes or progressors? Appropriate treatment strategy. Consult, counsel, combine, and monitor regularly. And taper and cessation of treatment. These are the impact, the mnemonic impact with which we can follow. That's a guideline. So identifying true axial myopia, we know from basic examination with cycloplegic refraction, biometry, K reading and axial length. We do biometry for every patient. We do a biometry by optical biometry by IOL master. Rule out any corneal or lenticular pathology because those are not for treatment for preventing progression, rule out pseudomyopia as already shown, and fundus examination. And mapping the risk factors, document risk factors, a detailed history with a questionnaire given to them. We have already seen that early age of onset, they have to be seen more often, and stress the importance of progression, lifestyle, of course, and how the pattern of lifestyle, whether the child goes out for outdoor activities, and excessive prolonged near work also, whether the child is stuck to the screen or the books, accommodation lag, near esophoria, and peripheral refraction is if possible. All these have to be considered. So pick the progressives. So who needs myopia progression management? Increase in myopic refraction of more than 0.5 diopter in a year. That is a minimum at which we would start treatment is at least minus 0.75 or minus 1 diopter, not less. Or an increase in axial length of at least more than 1.1 millimeter. Our focus group recently, we had a meeting for low dose atropine management, when we would start, when we would stop. Recently, for 1 week back, AIOS along with the AIMS had a meeting in Delhi, and they had some criteria given for these. This is the criteria followed. The progression of 0.5 diopter myopia and 0.1 millimeter axial length. So unless you have two readings suggestive of progression, you can just send the patient for myopia clinic. She has already shown the counseling done in myopia clinic, how you would encourage the lifestyle, modify the lifestyle activities by exposure to sunlight, and just give a routine glasses. That's all we would do. So appropriate treatment in every case, every case of myopia is unique. Not all cases are treated similarly. So you have the pharmacological control, low dose atropine, or the optical measures, which are progressive additional lenses, PAL, peripheral focusing, defocusing lenses, or ortho K. Low dose atropine is one of the earliest and more widely accepted one. Though not FDA approved elsewhere, we in India have the liberty of using it. The CDSC has approval in India between 6 to 13 years, which is approved by the CDSC. So high accommodation lag and near esophoria, they benefit better by a progressive ad. Stress on the importance of special lenses, especially when you get a peripheral hyperopic defocus, and spectacle correction is more compliant. Some patients, the parents especially, they prefer spectacle correction to medicines, and start with a mono treatment, and affordability is a factor too. So pharmacological, as we know, low dose atropine has been proven. 57% of myopia control is there by ATOMS 2 study, and LDA has to be started if there is an increase in myopia, as we have seen, and maybe started earlier in school-going children, or even earlier if the parents are myopic, where there is a progression, of course, and should be continued for at least 2 years, and then continue to teens if still there is a progression until stabilization is there. And if not responding, we can add another method or increase the dose of the atropine. Now 0.05 is also available. And a fast progressor or non-responder is considered as who progresses beyond minus 0.75 in a year. So, of course, we have talked a lot about the hyperopic defocus, which is the basis of optical control. And we know that this is the usual peripheral defocus this is an oblate shape of the eyeball, where even if routine concave lens is given, focusing is good at the fovea, but peripherally there is an hyperopic defocus, which we can correct by the myopic defocusing lenses or the spatial lenses. And this is our myopia clinic with an open field. We have an open field refractometer which gives the peripheral refraction as well. But other than that, we are trying to make 2 fixation points and see peripheral refraction by a routine method, so that we can make it more practical even if we don't have a an open field refractometer, which is mostly the Grand Seiko, this 5500, that is the commonly used one, which mostly a research tool, but it definitely gives an accommodation lag can be measured and peripheral refraction. So how we can go about it, whether to make it compulsorily mandatory for a peripheral refraction is a debatable point. But there are some custom-made peripheral refraction devices, not very expensive as this autorefractometer. And this is how you would do a 25-degree peripheral refraction can be made with a device like this. Or you can make a fixation target on your trial frame also. This is devised by Jitendra Jetani by fixing 2 targets when doing retinoscopy to do the peripheral. And this is the a modern sort of topography. Multispectral refraction topography may be the future because it gives retinoscopy at different areas. That is a newer addition to this. So in patients with hyperopic defocus as shown with the peripheral refraction, these DIMS and all the myopic defocus lenses might be a better choice. Multifocal center distance control lenses are also available, and which is not very popular in India because of the risk for infection. We don't encourage that. It is approved, FDA approved in Western countries. So ortho-K lenses gives almost 60% control, though it's not also very popular here. And it all depends on the choice of the child, the parent also. I'll just go through some of the cases. A boy of 12 who was being followed up regularly with low-dose atropine came after 15-month interval, and his refractive correction had suddenly increased from -3.5 to 5.25. With the cylinder was there even before, and the retinoscopy at center and nasal and temporal showed a difference of 1 diopter. And so we counseled him to have myopia control glasses, and we can convince them if we can do the peripheral refraction better. So this child became stabilized with, at least for a year, it was stabilized. So near work and lack of accommodation is another factor. Prolonged near work and reading with a lack of accommodation produces hyperopic defocus. This you can see when the child focuses for near, if accommodation is not there and it doesn't focus on the fovea, then again there is the hyperopic defocus even for near. And in these cases, PAL or progressive additional lenses may be a better choice. It's a very simple, actually, dynamic retinoscopy, MEM retinoscopy is not a very troublesome procedure. Just ask the child to look at where you are doing you can use the MEM cards, but even otherwise you can ask the patient to focus on your retinoscope with a target and do a retinoscopy. A normal is plus 0.75 to 1. And if it is more, then you can give an additional correction. Near esophoria is not very commonly seen, but if it is there, just do a cover test. If there is an esophoria, then you can definitely look for accommodative lag, and AC by A ratio can also be assessed. So this 10-year-old child with a -5 diopter had an increase of 1 diopter in a year, and the mother complained about her reading books with at close quarters. And we looked for near esophoria, it was not there, but MEM showed a lag of 1 diopter, and we gave her bifocals, and the next 2 6-monthly follow-ups, she was stabilized. So consult, counsel, combine, and monitor very closely. All these have been already discussed, but monitoring is very, very important. Every 6 months, you have to bring them back and see whether there is a progression, especially so when there are the other risk factors like parental myopia. And then you may have to switch to another mode of preventing progression or increase the low dose atropine from 0.01 to 0.05. And tapering and cessation, it can be continued even up to teens, but minimum 2 years you have to continue with your strategy. And myopia control glasses can be used even to late teens. and tapering atropine by alternate days and then weekly, and slowly you have to stop to prevent rebound. And pre-myopia, as we have discussed over the past 2-3 days, I've been hearing that encourage outdoor activities and exposure to sunlight, and they need close monitoring. So, lifestyle changes, encourage using TV instead of smartphone, pick up the progressors, evaluate binocular status as well, and myopia control strategy to be taken up whenever necessary and appropriately monitored. That is the most important thing. Thank you.